Hello, everyone. Thank you for joining today's briefing, the state of HIV/AIDS progress and applying lessons learned to current public health emergencies. My name is OK Enya. I serve as the Senior Policy Advisor at the Alliance for Health Policy. For those who are not familiar with the Alliance, welcome. We are a nonpartisan resource for the policy community that is dedicated to advancing knowledge and understanding of health policy issues. On today's briefing is generously supported by NICM, the National Institute for Healthcare Management. You can join today's conversation on Twitter using the hashtag AllHealthLive and join our community, All Health Policy, as well as on Facebook and LinkedIn. On today's panel, we have a Q&A section at the end of the hour. We want you all to be active participants, so please get your questions ready. You should see a dashboard on the right side of your web browser that has a speech bubble icon with a question mark. You can use that speech bubble icon to submit questions you have for the panelists at any time. We will then collect these questions and address them during the broadcast. And throughout the webinar, you can also chat about any technical issues that they may have, and someone will attempt to help you. Now I'm excited to bring up Dr. Anand Parak, our great moderator for this event. Dr. Parak is a Chief Medical Advisor at the Bipartisan Policy Center, which serves to provide clinical and public health expertise across the organization. Prior to joining the Bipartisan Policy Center, he completed a decade of service at the U.S. Department of Health and Human Services. In his time at HHS, he developed and implemented national issues focused on prevention, wellness, and care management. As well, Dr. Parak is a board-certified internal medicine physician, a fellow of the American College of Physicians, an adjunct professor for health management and policy at the University of Michigan School of Public Health, and an adjunct assistant professor of medicine at Johns Hopkins University. Dr. Parak, we're so excited to have you here with us today, and I'll turn it over to you.
Okay, thanks so much for that wonderful introduction, and thanks to the Alliance for getting us all together, for focusing on this really important topic, and putting together just a terrific panel. I'm really excited to moderate today's discussion. The bios of the panelists are in the material that you have, but I want to just briefly provide their top line bios so you know who we have today. First, we have Lindsay Dawson. Lindsay is the Associate Director of HIV Policy and Director of LGBTQ Health Policy at the Kaiser Family Foundation. She conducts research and analysis on domestic HIV policy, and her work focuses on how health systems, insurance coverage, and federal funding impact access to care for people with HIV and the programs that serve them. Next, we have Antoinette Jones. Antoinette is a HIV public speaker and advocate for the Positive Women's Network. She identifies as a vertical woman living with HIV, meaning she's been living with HIV since birth. She was called to peer advocacy to combat the isolation many people with HIV go through due to the lack of awareness. She's worked with many organizations serving Black women and people of transgender experience developing programs, advancements in healthcare services, and mentorship and leadership development. And lastly, we have Dr. Amish Adalja, a senior scholar at the Johns Hopkins Center for Health Security and an adjunct assistant professor at the Johns Hopkins Bloomberg School of Public Health and an affiliate of the Johns Hopkins Center for Global Health. His work is focused on emerging infectious diseases, pandemic preparedness. I think many of you have probably seen him on television over the last couple of years providing expert counsel on COVID-19, as well as an expert on biosecurity. Dr. Adalja is a fellow of the Infectious Disease Society of America, the American College of Physicians, and the American College of Emergency Physicians. So just a terrific panel. Each of them have a short presentation. So we're going to start with Lindsay, move to Amish, and then Antoinette. And then I have a round of questions, and please feel free also to add your questions throughout our event today. So with that, Lindsay, the floor is yours. Thanks for being with us.
Thank you so much for having me. It's a pleasure to be here. As my slides come up, I just want to say that It's really wonderful to be with this panel, and I think it's a really exciting topic. In case you're not familiar with the Kaiser Family Foundation, which I am guessing many of you are, we are a nonpartisan, non-advocacy health policy organization. My work is in HIV, LGBTQ+ work, and now COVID-19 and monkeypox as well. So what I hope to do in this short presentation is to just do some level setting, so that as we begin this conversation about the state of HIV in the United States and the impact our understanding of HIV has had on other pandemics and epidemics and other emerging infectious diseases, we all have some groundwork and baseline knowledge to start us off in a good place for that conversation. Slide, please. So the HIV was identified in the United States the first time in 1981, and it's been an evolving epidemic since that point. There are today 1.2 million people living with HIV, and this is both a success story and points to challenges. So the success is that thanks to highly effective antiretroviral therapies, that people are living longer and healthier lives, that people with HIV can have a near normal life expectancy and expect to die of things totally unrelated from HIV, if you have that access to care and treatment. But at the same time, we're seeing about 35,000 new infections a year. And so that means that that number keeps going up for those two reasons. And there has been a decline in recent years, but it's not at the rate that we'd like to see. It's not at the rate to meet the Ending the HIV Epidemic Initiative targets. And disparities within these new infections and within people who are already living with HIV exist, particularly among people of color, including Black people and Latino people in the United States. People living in the South are disproportionately impacted, as are gay and bisexual men and other men who have sex with men and transgender women. And so despite these challenges, there are new opportunities, and particularly in prevention domains. So we'll hear a lot about treatment as well from Dr. Aldeja. And namely with PrEP, which is really underutilized in the United States to prevent HIV. It's 99% effective at preventing HIV acquisition through sex, and treatment is prevention, which is the notion that if you have HIV and you take antiretrovirals and the amount of virus in your body becomes undetectable, that not only can you enjoy individual health optimal health outcomes, but that you can't transmit HIV to others. So it becomes a prevention modality. And it also affords the individual protective mental health benefits, right? You know that you can enjoy intimate relationships without fear of transmitting HIV. Slide, please. The other way I think that's helpful to think about the HIV and the epidemic in the US is to look at the care continuum. So if you imagine the 1.2 million people living with HIV in the United States, 87% of people are diagnosed, 66% are receiving care, half are retained in care multiple times a year, and 57% are virally suppressed. So really able to have that optimal health outcome and harness that preventive benefit. So that 57% has gone up from 49% in 2014, which is good. But when we look to how the US compares to other countries, slide please, we see that US actually isn't faring very well. And that's when we compare it to other high income, otherwise comparable countries. And when we look at the sort of far left-hand side of this slide, it's really not doing well compared to countries like Switzerland, the UK, and Sweden. And there are a lot of reasons for this. It's not just an HIV thing. We could do a similar slide with other diseases or other health indicators and see similar results. The US is very different. We have a really complex health system. We have people who are uninsured, particularly in Medicaid non-expansion states. There's more income inequality that can drive this. People are on lower incomes in certain communities compared to other countries. We see higher costs of healthcare, particularly in physician payments and hospital payments and drug access. And despite those higher costs and higher spending, we don't necessarily see the same sort of health benefits. And so those are some of the reasons we might be seeing this, but I think it's important to acknowledge as we think about how the US is doing. Slide, please. And these are my final two slides. I think the other, I wanted to give you a big picture of the epidemiology. But when we think about the epidemiology and how that marries with policy, a really important piece of this is the federal funding landscape. So the US funds HIV at about $35 billion a year. This is FY 2019 funding. We're working on updating this shortly, and that'll be available on our website. The bulk of HIV funding is spent on domestic care and treatment, and within that slice of the pie, most of that is actually Medicare and Medicaid spending, and a smaller share of it is Ryan White. About a fifth of spending is to the global effort. A less than 10% goes to domestic research. Most of that happens at the NIH, and about 3% goes to prevention, and most of that's happening at the CDC. So pretty small slices of the HIV budget go to care and go to prevention and research. The other really important way to look at this is the split between mandatory and discretionary funding. If we look at the funding over time from 1981 to 2019, we do see this sort of sharp increase in consistent funding that's happening for HIV. But when we look at the discretionary funding, which is the funding that Congress appropriates, we see that that really increased over time, and then since the 2000s has more or less leveled off. And what has increased is actually the mandatory spending. So mandatory spending here is mainly Medicare, Medicaid, Social Security disability, and that is funding that's meeting care needs, it's meeting increase in population, it's meeting increase in drug spending, and that's what's really driving the increases. Slide, please. And this is a look at one program. It's my last slide. I think having a look at one program and zeroing in helps us better understand what the appropriations look like. So this is for the Ryan White program, which is the Care and Safety Net program for people with HIV in the United States. It serves about half of people with HIV. And we see that at the program's inception, we see pretty sharp increases up until the 2000s, more gradual increases, and then a real leveling off. And those more recent increases you see in the last couple of years are for additional ending the epidemic funding that was appropriated to the program. But when we hold the program's funding constant for inflation, we see that there's actually been a decline in funding. And so I think this challenges in some way our response, particularly when programs like Ryan White are being asked to do more to address COVID and to address the monkeypox outbreak. And so hopefully this sets the stage and provides us with a nice jumping off point for the rest of the conversation. Thank you.
Lindsay, thank you. That was just a terrific overview and absolutely forms the basis for our conversation. So, and let me turn to Dr. Adalja now to continue the presentation.
Thank you for the introduction. Thank you for inviting me to speak. So in the next 5 or so minutes, I'm going to try and give you sort of an overview as a clinician and as somebody who studies emerging infectious diseases, looking at HIV through that vantage point with the eye of thinking about how this applies to other emerging infectious diseases. So I think if you think about HIV, it is the prototypical emerging infectious disease. And I think most people don't think about it that way because it's been in public consciousness since the early 80s. But this was a virus that jumped from an animal species to humans, probably around the turn of the century, the turn of the 20th century, so in the early 1900s, in Africa, and was spreading kind of surreptitiously, unnoticed until it actually started impacting Western countries in the 1980s, which is the norm when it comes to emerging infectious diseases. And this was a disease that was 100% lethal, for which there wasn't much known. And next slide. There are so many things that have happened. And I just put this slide here just to talk about all that's happened in that time. So what we saw was a concerted effort, and a lot of this was done, in the absence of formal declarations of public health emergencies, where the industry and government sort of combined together. And you can see there's a timeline there on that slide. That's the number of drugs that have been approved for HIV since the inception, starting with AZT in 1981 to new drugs that are being approved almost yearly, where we went from having no treatments, and the treatments that we did have didn't prolong life, to treatments that basically are one pill once a day, or now an injection every several weeks that can keep you free from the complications of HIV. I think this is a tremendous biomedical revolution that's really underappreciated. And what you can see is that people now can have a normal lifespan if they are able to be treated with these miraculous drugs. And as you heard the prior speaker allude to, we've now allowed people to basically resume their normal life, because if you have an undetectable viral load, the HIV is untransmittable, meaning those individuals can have normal sexual relations and not worry about transmission of HIV, which I think, going back to thinking about what HIV was like even in the 1990s, is tremendous. We also have home tests for HIV. This was the actual only infectious disease home test that was ever approved prior to COVID-19. And it was, I think, a decade's worth of work from the company to prove that this could be something people could do at home. And look at how well home tests have influenced COVID-19, the trajectory, because what you have is people being able to be empowered to take actions, to call their doctor for an antiviral, to isolate, to quarantine, to tell their contacts that they have COVID. All of that kind of stems from the work that was done with HIV and these home tests. Next slide. We still, however, have about 30,000 or so cases that are occurring every year in the United States, and I suspect that that will probably go up with the after effects of the pandemic. But because of that, it's really important not just to have treatment, but to have prevention. And we have pre-exposure prophylaxis, which I think was also kind of an earth-shattering advance, because people who are at risk for HIV can take medications that prevent them from getting HIV. Initially, it was pills. Now we have injectable versions of this, where you don't have to be taking a pill every day, but get an injection every 2 months. This is a major technological advance in allowing HIV to become a much more manageable risk than it ever had been. Again, something that's unprecedented for any other infectious disease, but something that's really not well appreciated. Next slide. And it's not as if HIV advances have stopped. This is probably one of the most prolific areas of research in infectious disease. HIV does have an outstanding, this enormous influence in infectious disease research, and we're still going further and further. And I think in the years to come, you're going to see new classes of drugs. You're going to see what are called broadly neutralizing monoclonal antibodies. So people are interested in monoclonal antibodies because they've heard about their use in COVID. We use drugs like Evishield or bebtelovimab for treatment of COVID. Those monoclonal antibody type approaches could apply to HIV. That's another cutting edge area of research, as well as vaccines. We had a trial in Thailand several years ago that had a positive impact. It wasn't something that was a record-breaking type of vaccine, but it showed that a vaccine approach is possible. So this is something that is still a major priority to controlling HIV. And we've had several patients that were quote unquote cured of HIV. Obviously, those were not representative of how we treat HIV with bone marrow transplants and the like, but it actually shows that this is something, and it's proof of concept. This is something that can be achieved. So I think when you look at the way HIV has kind of marched over these last several decades, it can only be seen as a success story for what the human mind can do when concerted effort is made to tackle a problem that was insoluble, a virus that no one had ever heard of, for which we didn't have a test, we didn't understand transmission back in 1981, to probably the virus, or clearly the virus that has the most tools to deal with it in terms of antivirals, pre-exposure prophylaxis, home tests. And I think thinking about when we think about emerging infectious diseases that establish themselves in the human population, think about how all those lessons apply to, for example, COVID-19, home tests, preventive monoclonal antibodies like Evishield, antiviral therapies. All of that really is paradigmatic. And I think taking that HIV paradigm and actually shrinking it, making it faster and faster to get all of those tools, which we can do with the new technologies, I think really portends for a good future with our ability to battle emerging infectious diseases, but only if there's political will to do it, only if people actually take the threat seriously, because I think the science is there. It's about the willingness to actually implement it. So I hope that was interesting. Thanks again for inviting.
Thank you, Dr. Adalja. Great, and now we'll hear from Antoinette Jones.
Awesome. Thank you so much. Greetings, everyone. I hope you all can hear me, and thank you so much to the Alliance for creating space and to allow me to share my lived experiences and my passions for advocating for people born with HIV. I do not have a slide. I just have a brief just sharing my experiences. So I'm from the Bronx, New York, and I was born in 1994, during a time when the world began to see a bit of advancements in HIV, such as the provisions for of AZT to pregnant and birthing people in order to prevent the transmission of HIV. In my case, I like to say that I just missed the mark, but that allowed me to stand here 27 years later to share my diagnosis experience, as well as my journey to bring awareness to other verticals who have similar experiences. And please excuse any noise you may hear in the background. I also parent many children along with my own. But I started my work in advocacy in my early 20s as a peer navigator, facilitating access to preventive and care treatment services, so STD, HIV and STD testing. And that has allowed me to open my eyes to the needs of the community of people who are not living with HIV virus. But a lot of my work was specific to providing peer supportive services to women aging out of pediatric care. And as a person who has had a difficult experience of the transition, I provided guidance from what it will look like to move from a dependent care service to an independent care service. And in my advocacy efforts, I work to combat the isolation that many people who are born with HIV go through due to the lack of awareness and supportive services. So I believe that by empowering vertical people aging with HIV to take charge of their sexual health and their wellness, giving them the tools that they need in order to advance their healthcare journeys, normalizing HIV to be a human diagnosis and not something that attacks a specific community, addressing the traumas that impact people who are born with HIV, and the stigma that is associated with the diagnosis in itself. And all of these things that I do will further advance the lifespans of people living with HIV and the recognition of people who are born with the virus. I continue to do a lot of work with organizations. As was said, a lot of my support is addressing the intersections of HIV in marginalized communities, so specific to Black people, LGBTQ, queer folks, trans-identified folks, and just working with organizations to advance their programs and their meaningful involvement of people living with HIV, advancing in healthcare services, mentorship and leadership advancements in services and development, and making sure that people who are living with HIV are at these tables and are making decisions. And I also work with HIV providers to improve healthcare services for people who are living with HIV, and just being sure to provide an overall holistic care service that is working together, that is developing the needs and not the provider making decisions for the patients, but they are working together to make decisions to advance the care services and our lives. So yeah, thank you so much for allowing me to be here, and I can't wait to just share some more.
That's great, Antoinette. Thank you so much for everything you're doing. And now let me invite all of our panelists back on. And just a note to the audience as well, you can submit questions to the panelists using the question mark button on your attendee interface. I'm going to start off with a couple of questions to all of you, and then hopefully we can involve the audience. So great presentations. This is the first question to all of you. Is how would you characterize the state of the HIV/AIDS epidemic in this country? I recall back in 2010 when I was at HHS, the first national strategy for HIV/AIDS was released, and on one hand, many of the top line numbers that we still hear about, 1 million or so individuals with HIV, 30, 40,000 new cases, 10 to 15% not knowing their status. We're still far away from sort of 90, 90. Many of those top line numbers still seem to be pretty much the same. And so I guess the first question is, do you all feel like we have stalled to a certain extent in our fight against the HIV/AIDS epidemic, or is there really momentum that lies underneath those high level numbers, how would you characterize sort of the state of where we are in the US with respect to HIV/AIDS? And anyone can start.
Yeah, I'll take the first stab at this. I think that there is sort of been a stalling. I think that there are, at least from the medical standpoint, as I said, we've got all of these great tools, but they're still underutilized. So if you remember Lindsay's first slide, she talked about 87% of people know that they have HIV. There's 13% that don't know they have HIV. That's an issue. And only less than 60% of people are virally suppressed. And that's the key to making HIV manageable, is getting them virally suppressed. So there is this gap of about 40% of people with HIV that are still infectious, still suffering the consequences of HIV doing destruction to their immune system. And think about PrEP. PrEP is a great thing, but only about 10% of the eligible population for PrEP is actually getting PrEP. So we've got all of these great tools. They're just not being utilized. And I think that's the key to the next stage of dealing with HIV, is having numbers like Switzerland has. And I think trying to reach those populations that are not having the ability to use these tools, that's going to be the key thing to making this something that is even more manageable than it's become.
Yeah, I couldn't agree more with that. And I think, the state of HIV is very focused on subpopulations, right? So if you're a white person in an urban area with access to great HIV care, and you're moderately, you have a moderate income, and good access to doctors and health insurance, you likely have very good access to HIV care and can get to that undetectable level. But as we see with disparities in viral suppression, we see that white people, Asian people, multiracial people have higher rates of viral suppression than do Black people and Latino people in the United States. And this speaks to underlying structural inequalities. And we see the same thing with COVID-19. We see the same thing with MPOX. And so it's getting at some of those more entrenched inequalities that are going to make the difference in improving some of these disparities and closing that gap with HIV.
I would also agree with everything that has been said. So I see a twofold. I see that there has been improvements in healthcare access, such as like medication milestones and improvements in research that has allowed people like myself to live longer and sustainable lives. But on the other hand, we still have the impact of like internal and external stigma that greatly forces people into isolation, self-hate, self-harm, and even like situations of intimate partner violence that really has ended people's lives. And then in many states, there's still very, very harmful legislation that criminalizes people for living with HIV that also pushes fear and stigma, but it actually works against public health efforts in ending this epidemic and like just further pushing our goals. So.
Thank you. It's very helpful. In your presentations, you talked about, obviously, advances in science have been tremendous. Lindsay, you covered a number of the government programs, maybe a little bit off script here, but if I could ask each of you, given where we are, if there was one action that could be taken, it could be a government agency, it could be a health professional group, it could be campaign to break down stigma. If there's sort of one action that could really jumpstart our progress or catalyze further progress, what would that one action that we ought to take as a society right now, and who would be the lead in terms of taking that action? Not to put you all on the spot, but anyone can start with that.
To me, I think it's trying to get the number of new infections down. And if we've got 30 to 35,000 infections occurring every year, despite all these tools, I think we have to use those tools better. As I've said, it's kind of the theme of what I've been saying. So there, I think pre-exposure prophylaxis, I think there's, if only 10% of the population that's eligible for PrEP is getting it, there's a major gap there. And it's often people who don't know their HIV status, don't know they're infected, that can spread it. So I think getting that at-risk population to take advantage of those tools, and I don't know what the best means means of this would be or what government organization would be, but I think it has to be getting more people on pre-exposure prophylaxis if we're going to have any dent in the incidence of HIV.
Yeah, I think that's very important, and at least one of the barriers in terms of health insurance, given that it is a U.S. Preventive Service Task Force recommended service, should be less. It should be available without cost sharing, putting aside for a moment that the recent Braidwood Management versus Becerra case that we've heard that could jeopardize access to that. But really figuring out how we increase access to PrEP for those at highest risk, I think very, very important. Other thoughts, Lindsay, Antoinette?
Yeah, I mean, I think it's something that I've been wondering about, and we've been talking about it on my team at KFF, is whether or not there is an ability to leverage federal grant making to more directly encourage some of the steps that we'd want to see. So I think there's two SAMHSA grants now that are requiring an HIV intervention, and I can't remember if it's a conversation around PrEP or if it's a conversation around HIV testing. But we don't see that very often with Ryan White grants or CDC prevention grants, that, hey, if you take this funding, it's a requirement that people who use these services get XYZ intervention. And it's possible that something more directive around PrEP or around treatment adherence or around screening for intimate partner violence would have leverage in shifting at least conversations in HIV care and support settings.
And that goes beyond, you're saying, the HRSA Ryan White CARE Act.
Yeah, I'm saying it could be part of that. It could be part of a Ryan White grant, or it could be part of a CDC prevention grant, just as SAMHSA is integrating this into some of their recent grant making.
Great. Antoinette?
I loved everything that was said, especially around the barriers, and I wanted to just further express how do we address the barriers to access that prohibit the at-risk population from getting things like PrEP or even just staying in care. So affordability, insurance, transportation, awareness and education. How many communities do we know of outside of the MSM community that really uses PrEP as a prevention tool? And how can we get them to start being more aware and understanding that this is a tool to help prevent the transmission of HIV? So how are we increasing trust in these communities to further reduce HIV transmission? But how are we directing our efforts towards the communities who we believe don't need it, but they really do? Yeah.
And how does sort of the changing face, to a certain extent, of the epidemic? I think we're seeing more infections in the last few years, more in the South, some more in even suburban and rural areas. Certainly, we've talked about sort of the MSM population and young and in communities of color, but there is a little bit of a changing of the face of the epidemic, and how do we make sure that we are responsive to that? I guess that gets to Antoinette's point that we need to really, build trust in many of the communities.
I think it's going to be very challenging. As we've seen with the monkeypox outbreak, that when outbreaks change their demographics, it becomes difficult, or if there's different demographics, or certain demographic groups are going to have more access and easier to reach than others. And if you look at what's happening with HIV, it's becoming younger and more color and more people of color being infected, which is much more challenging, especially where there may not necessarily be the same resources that there are for the traditional populations that have been associated with HIV. And the thing is that the control will slip if you actually don't target your interventions towards people who are actually going to benefit from it. So if you're not using the tools in their most impactful way, we will actually see cases increase. We will lose that ability to control it, which we've seen which was the case with monkeypox, when you saw vaccines not going to the people that were at highest risk. That doesn't actually help you gain control. So I think it's incumbent upon us to actually use the epidemiology to target interventions. And I think you have to find many different avenues to do this, but it's very, very challenging, and it's a lot of on the ground peer-to-peer type of work that's going to be how those individuals get reached and get connected to treatment or prevention.
Yeah, I think sort of this piece that you just ended on, the peer-to-peer element, and engaging communities early and often in every stage of intervention is so critical to the response. And it can't happen at the point where a federal agency has a campaign that they've essentially done in the Ready to Focus group. It has to be early on to get community buy-in, understand what's happening within a community, and engage in the response. Certainly with monkeypox that you brought up, we're already seeing that 75% of cases are among Black and Latino people in the United States. And despite that, we're seeing a very small share of vaccinations in these same groups. And the cases are way disproportionate to the share of the population that these groups make up. And so engaging in both prevention and treatment modalities as well is really critical. So both on sort of the PrEP and the treatment as prevention side, but the engagement and care and treatment side in HIV as well.
So a very similar theme I'm hearing, and we can also transition to monkeypox and COVID now, but the inability to ensure that those at highest risk have access to these wonderful tools that we have for prevention and treatment. Maybe the first question as we sort of think about how all of these epidemics are related. Obviously, some things have worked as we've combated HIV, and are there some lessons learned from how we've dealt with HIV that could be helpful? We've just talked a little bit about one when it comes to continuing the fight against COVID as well as battling monkeypox. Additional lessons learned from our HIV/AIDS experience that we should be mindful of.
One thing that comes to mind is the fact that of those people who have benefited from the HIV treatments, there's great enthusiasm over it, that there's this, they call it the Lazarus Effect, and people being really aggressively wanting to take advantage of all of these new advances in terms of one pill once a day or injectables or PrEP in that group that's in tune with all of that. But we've seen sort of the opposite with COVID, where you actually have people that are turning away from those tools, that they don't want the vaccine, or they don't want Paxlovid, or the monoclonal antibodies sit on shelves unused. All of that, I think, is, it's the opposite. With HIV, people were literally dying for those treatments. Here, people are shunning it. And I don't know what the answer to this is. I think it's very scary. It reminds me sort of a Dark Ages type of mentality, where the tools that we have for COVID, which are probably the most for any other respiratory virus. I wish we had the tools for flu that we have for COVID. They're being shunned. And that's a different problem, because even though HIV has always been tied with politics, I don't think that it came through the filter of identity politics the way that COVID did. And we know that HIV, there was stigmatization and a lot of ignorance about some of it. But it's a whole different brand, I think, with COVID-19 that we saw with HIV. And I think that's a bigger challenge than we ever had with HIV, because I don't know how we get those people engaged again in this battle against infectious disease, because you're seeing it even erode in childhood immunization rates falling, influenza vaccination rates falling. That's scary, and massive loss of trust with public health authorities and even infectious disease physicians in a way that there weren't with HIV. Nobody didn't trust. I mean, it was actually the other way. It was actually HIV advocates that didn't trust the CDC. Now it's the other way around. It's to me very puzzling, and I think it doesn't portend anything good in terms of infectious disease control in the future.
Yeah, it's interesting. I think, COVID-19 is very different from either HIV or monkeypox. Both monkeypox and HIV targeted much smaller communities and communities that were facing stigma and discrimination. And so the challenges there are very unique. Whereas it's much more diffuse with COVID-19. But in terms of lessons learned, I think, certainly we've talked a lot about the need to involve the community. I think that's important. I think monitoring disparities and using that data to be able to respond to that is critical. there are some challenges with that. Certainly, there are limitations to the data that we're seeing coming in from monkeypox. We're not getting it from all jurisdictions at this point. And then I think, having a public health approach is really important here. So having one that destigmatizes disease and seeking treatment and prevention services, having a no wrong door approach to care, treatment, and prevention is really important, right? That whatever door you go through, that you could talk to a provider about getting HIV care, treatment, or testing. We know that's not the case in the United States, but that is a sort of the approach that would make HIV care, treatment, and prevention more accessible. And then to take a harm reduction approach as well, right? So that, yes, we know the best case scenario for HIV care and prevention, but we also have to meet people where they are and engage them in ways that is working in their lives in an important way. And, notably, the people who are in charge of the domestic COVID-19 and monkeypox response are HIV physicians, right? Like Dr. Walensky, Dr. Fauci, Dr. Deskalakis, Dr. Merman. These folks have this HIV history, and they are bringing it to the monkeypox and COVID-19 response.
I just wanted to add one thing. I didn't mention harm reduction. I think that's a really important lesson that I try to talk about in the press, is that a lot of COVID-19 was abstinence only. And it's not surprising that it failed. It's not surprising that most people lied about their activities, because we know that abstinence only doesn't work in any situation. And for so long during the COVID-19 pandemic, that's what the actual official government policy was, even though many of us were saying harm reduction, risk calculation, people will just give people tools and they'll actually modify their behavior. And I think that would have avoided some of the politicization that happened if we would have had an harm reduction approach, rather than the shaming and all of that went on for people who were trying to pursue whatever their values were, but it didn't it involved some COVID risk in, and that was just, I think, something that got ignored. And hopefully now we're getting to that point with COVID-19. We definitely, with monkeypox, as Lindsay said, have that harm reduction approach because it was natural, because of the leaders that were running that response.
Great point. Antoinette?
I wanted to add that I hear everything that everyone said, but there is a major and a generational, it has been ongoing for a very long time, mistrust in the medical community, and it's historic, but it's based on the harm that has been done to Black and brown people. And that feeling is so embedded in the DNA of Black and brown people that it probably would never go away. So the way to engage people who are living with HIV is going to look different than people who are not living with HIV, because people who are living with HIV had more of a hands-on and a witnessing approach to seeing the progression of the HIV virus. So of course they are going to be a lot more trusting and eager to receive the COVID-19 vaccine and even the monkeypox vaccine, because we are very, very closer to science than the rest of our community who is not living with the virus. So I think in order to not see the same things happen that we have seen in the HIV epidemic, we want to definitely do a harms-free approach, but increased hands-on community support is important. That peer-to-peer support, providing resources and education is important, especially when it comes to research and sharing back the research to the community that they have been involved in. And then also access is really important, and making sure that folks are able to get to these testing locations or these vaccine sites in order to, increase those numbers that folks want to see, as well as prevent further cases.
That's great. It's such a critical theme to really empower peer support specialists, community health workers, and individuals who are trusted in the community, who have lived experience, to be the ones to connect those at highest risk for all the important scientific tools that we have out there, from tests to prevention and treatment. So I think that's a really important takeaway. I do want to come back to the politicization question. Amish, that you were discussing, and I guess coming from the Bipartisan Policy Center, I guess you would figure I would ask a question about this, but certainly we've seen politicization with respect to COVID. HIV traditionally, comparatively, has been bipartisan. You think about the Ryan White Care Act globally, you think about PEPFAR. How do we make sure we keep this bipartisan on the HIV side and not get caught up in the politics of responding to more recent pandemics? What advice would you have for policymakers to keep this bipartisan?
And the thing I think is that I say is almost have the subject matter experts leading this. It's not, when you have politicians involved, it's going to become political just by definition, because when they view a public health emergency as a way to get a one-up on the other party, or they think about, you know, the rate of boosters or the low rate of boosters as a win or a loss for them, rather than actually thinking about the infectious disease issue, that's what lends itself to that. And both parties are completely guilty of this through two different administrations during COVID-19, is that they don't actually think about what's going on the ground, what's the public health emergency, what do we need to fix here. They think, you know, this is going to be good for my polling, or they shouldn't even be asking polling questions, politicians, about infectious disease, because that's not something that should be in their purview. It really needs, I always say the CDC needs to be almost like separate from the government, like the Federal Reserve, which itself isn't very separate, but it's sort of separate. I think that there just needs to be some insulation so that it's not sucked into the vortex of the day-to-day getting a one-up on your political opponent. But it's very hard, and I don't know what would happen if HIV occurred now. I think it probably would be politicized, because everything is politicized now. It's just, we've gotten to this point where it's very tribal, and identity politics rules the day with no matter what, and infectious disease is no different now. So it's really the politicians have to be banned from being involved in infectious disease outbreak. I mean, that's the most stark way to put it, is it's when they're there, it's their presence that actually causes it. And I'm not very optimistic about this. I think that bipartisanship is mostly dead. And maybe there's some historical remnants of it that are there, but I'm just burned by the whole COVID experience. And I was somebody who went on, you know, Fox, CNN, MSNBC, and the hate mail I got on all three networks all the time just tells me that whatever tribe is mad at you, it just doesn't end. And I don't know that was ever something that happened with HIV.
Yeah. Thank you for that. Yeah, please go ahead.
I was going to say, I think it's important to remember too that there was a period before Ryan White and before PEPFAR. So, you know, HIV is uniquely bipartisan now, absolutely. But it wasn't initially. And there was this time of, I mean, HIV is still too stigmatized. But there was a time of even deeper stigma. We had a sitting president that didn't mention HIV/AIDS until 1985. And that bipartisanship took a lot of coalition building. And it wasn't a given. And advocates made inroads in the agencies. So advocates were deeply involved in evolving policy at the FDA, changing regulatory pathways, and at NIH, having conversations about what clinical trials should look like. And similar conversations were happening on the Hill. And so that bipartisanship was fought for, and once it coalesced, we did have the Ryan White Act passed in 1990, and it passed the Senate by a margin of 95-4. And so I think that is an important part of the history, and that because of the bipartisanship, the HIV is somewhat protected now in a way that we don't see around other issues. But I also totally agree with Dr. Adeja around the need to have a depoliticized, science-based approach to these conversations with leadership. And that's because the second you say something that is partisan or it's based in politics, there's going to be fear associated with it, right? And it's hard to do something when you're coming from a place of fear and threat. But if you're coming from a place of a knowledge base and a science base, it might be easier to make political decisions. And I realize that that's easier said than done, but.
That's great. Terrific historical context. Antoinette? Well, one more policy question to throw at you. So we've talked about HIV, COVID. monkeypox. I mean, there will inevitably be future infectious disease outbreaks, epidemics, pandemics. We've talked about preparedness a lot. We still have to improve there. What are the one or two most important things as we face all of these, and we know we're going to face more in the future, that we need to do when it comes to infectious disease preparedness?
The biggest thing to me is that we have to start thinking about public health emergency management the way we think about national security. It can't be subject to boom and bust, panic neglect cycles where there is just this tendency to be very reactive. So after COVID, after HIV, after monkeypox, after Zika, they worry about it for a while and then it recedes from the headlines and it becomes less of a priority. It needs to be sustainably funded over time and not something that can be subject to this kind of up and down, because that's impossible. When you saw what happened with COVID-19, the surges that we had in the pre-vaccine era, and the fact that health departments couldn't keep up with contact tracing, nobody should have been surprised, because they never hired those contact tracers because they couldn't do it. They didn't actually have the funding to do it. So I think if you don't actually fund the core functions of public health in a proper manner, you're always going to be left lagging. And we have to get politicians out of the mode of being reactive and not just thinking about the next election cycle, but thinking farther out. How do you build a sustainable system? The way they do in the Department of Defense when we're talking about national security threats, that needs to be, that type of thinking needs to be imbued into how we think about funding public health. And remember that, you know, in our military, we have tanks and fighter jets and all that. That's the equivalent to that is the CDC, it's diagnostic testing, it's public health labs, it's public health practitioners that can do contact tracing, all of that. And it's your infectious disease workforce. That has to be funded in a different way, or this whole thing is going to happen over and over and over again with this reactive stance.
Thank you. Lindsay, anything to add there?
Yeah, I mean, I think funding is a critical piece, right? And it's not just funding because the funding needs to be there for those responses, but that it's because right now we saw with COVID and the monkeypox response that workforce and resources were borrowed from the HIV response, right? So, and that was from the very highest levels of the federal government. Folks were diverted to work on these responses down to contact tracers working for a local health department. And so I think, you know, when you're keep borrowing from HIV to respond to other infectious diseases, the new infectious disease probably isn't going to get an adequate response, and it will probably be harmful to the HIV response as well. So I think that is a really important piece. And I think the other two pieces that we've talked about today several times around involving a community from the get-go is critical, and having science-based messaging.
Great. Well, we're now going to move to audience questions. We have quite a few already. And Antoinette, I think we'll start with you. The first audience question is, Ms. Jones mentioned the stigma issue with respect to HIV. Has she or any panelist seen any change, decrease in stigma and attitudes among minority communities toward MSM or HIV patients more generally? So are you seeing signs of decrease in stigma?
I've seen a decrease in stigma in MSM communities that I am familiar with, especially Black MSM communities, because of the culture and the safe space that they create for people living with HIV, and people who are not living with HIV, but they identify as MSMs or somebody who is queer or LGBTQ. That I don't see the same for people who are living with and not living with HIV outside of those communities. So cisgender women, there is still a high stigma amongst our community, as well as transgender women and transgender men, and all people of non-binary experience. But I think because of the supportive services that are offered within our communities, which has increased, as well as just that direct connection with providers and working with providers who understand the community aspect and the need in those marginalized communities and communities who do not have access to those as many services. we have seen a reduction in stigma, but there is still, it's still very stigmatized. Yeah.
Okay, thank you. Any other responses?
Yeah, I think Antoinette's last point is right on, that generally in the US, we see increasing acceptance of LGBTQ people, of same-sex marriage, and it tracks quite closely alongside things like marriage equality. And we see increasing LGBT identification, particularly among young people. But that stigma is still present. We still see that LGBT people have more problematic interactions with medical care systems, for example. And then when we go sort of deeper within this overall statistic and look at rich intersectional lives of people who are people of color and they're queer and they're living with HIV and they're low income, you can find stigma alive and well and really challenging folks' ability to engage in the care, treatment, and prevention they need.
Great, thank you. We have another question for Dr. Adalja. This is about cures. How much credence do you lend to the occasional reports of individuals cured of HIV or who have been found to have inherent immunity? Do you envision that HIV will become 100% curable, not just undetectable? And what's the expected time frame?
I think that the cures that occurred, specifically the ones that involve bone marrow transplants, are not something that's going to be generalizable to the population. Those are individuals who had leukemia, got a specific type of bone marrow transplant that was really ingenious and worked. And what it shows is that this is technically possible, and that there is, and I think that the value of those cases is really showing what the approach may be in the general population. And it's not necessarily going to be that specific mechanism that's going to be used, but I think it's the principle. And I think that this is not something that I think will happen in the next 5 to 10 years. I think it's very hard to get at that what's called that long-lived latent reservoir and activate it and eradicate it. So this is something I think is going to be eventually probably. I don't think it's beyond the bounds of science, but I don't think it's something that's going to happen in the near future. But I think hearing about these cases is really, it just shows that there is a scientific basis, that there is biological plausibility, that this isn't something that is insurmountable, whether it's even if it's not going to be that exact process that applies to every patient. But I think it is something that is inspiring and actually provides more impetus to actually get closer to that level. But I do think HIV will be curable at some point. I just don't think it's quite there yet. And these are more emblematic as examples of how it could be done rather than how it will be done.
Thank you. Another question from the audience about how COVID-19 exacerbated or has exacerbated HIV/AIDS in this country. The US announced in 2019 it wants to end the epidemic by 2030 by reducing new infections by 90%. Since this was pre-pandemic, how feasible is this now, or what are the biggest barriers? So the question is, we were on a trajectory, goals were set, then COVID hit. How much has COVID pushed us back in terms of achieving our HIV/AIDS goals?
I don't know that we've seen the whole impact, but if you can extrapolate from other sexually transmitted infections, we've seen loss of control in increasing rates of syphilis. We know that there's been decreased testing for sexually transmitted infections, including HIV, and testing is really part of that ability to decrease infections, as people knowing their status. There probably were less PrEP starts, people getting put on pre-exposure prophylaxis, there was massive disruption in HIV care as people kind of privileged COVID-19 over other problems, kind of being short-sighted, and a lot of us warned that was going to happen, but we're kind of shunned when we said that. It's important to actually make sure that hospitals are taking care of all of their other issues as well as COVID. So I do think that there's going to be a setback. How big it is, I don't know yet. I don't think that we have all the dust to settle to know what it would be, but I suspect it probably will put us back behind those goals that were once articulated, unless there's some major breakthrough like a vaccine comes to fruition faster than we believe it would.
Great. Lindsay, did you want to
Yeah, I mean, I don't have a tremendous amount to add. I think we need more data. CDC does have HIV data up for 2020, so that first pandemic year, but it isn't totally reliable. We don't know whether new HIV diagnoses weren't happening because people didn't have HIV, or because people were shut down and not going to get HIV. Certainly HIV services, both in terms of prevention and treatment, totally shut down or partially shut down or went remote, and staff got diverted early on. That did recover fairly quickly. Some evidence suggests that HIV testing returned to near pre-pandemic levels, but we'll have to see what the outcome is moving forward.
Great. Another question that's coming, what else can we learn from people living with HIV/AIDS that would be helpful in eradicating this disease? What are the current policy issues, agenda items that are pressing in the HIV/AIDS advocacy community? So I don't know, Antoinette, if you want to start there, or anyone else want to respond?
Can you repeat the question just one more time?
Yeah. I think the questioner is asking, what else can we learn from people living with HIV/AIDS that would be helpful in eradicating this disease? And are there any other current policy issues that are pressing in the HIV/AIDS advocacy community?
I think something that we learned was like the need for public health and just our officials to be proactive rather than reactive. So just making sure to have things regardless of the quote unquote need, because COVID, I think, exposed a lot of that, and like the need for services, for access, and for people to get the treatment that they need in order to keep them healthy. When it comes to some like policy, I think we have seen a replication of harm when it came to targeting a specific community when it comes to like an epidemic or outbreak. And that has like done more harm than good, because it leaves out a community that we are not really paying too much attention to. So just being sure that any policy is open to all people, and from like just a different perspective. So like, for example, and then also just pushing back on any legislation that we may see coming that is harmful. So like legislation against insurance companies providing support or providing, preventative care around STDs or HIV testing, or preventative care around PrEP. We have seen, because it targets or pushes a homosexual agenda. Anything like that is coming down the pipeline that we are like bound to see, especially after the overturn of Roe v. Wade, we should definitely keep our eyes out for, and be sure to like get ahead of it, and to combat the harm that it may cause nationwide. And I think legislation that we should also be mindful of is the decriminalization of HIV on a federal level, and the guidelines that are in support of that. So
Terrific. Any other comments on that one? We have one more audience question, which is global related. We haven't talked too much about the global epidemic. The question is, what more can you all share about the recent uptake in new infections in places like South Africa, and how we need to better adapt HIV prevention efforts globally? I will say for the audience, just so you know, that next year will be the 20th anniversary of PEPFAR. PEPFAR will be up for its 4th reauthorization, obviously probably the most successful global health program here in the United States, having now 20 million people on treatment, millions of people whose lives have been saved. But any comments on this question related to global prevention efforts and what we need to do there?
I would just say that you have to think about, even though HIV is one global pandemic, there are multiple mini epidemics within it. And drivers in given geographic areas may be different. So you can't have a one size fits all approach. You have to actually understand the epidemiology of infection in South Africa versus epidemiology in Chicago versus epidemiology in Pittsburgh, and then direct those activities that way. So it's really important to be adaptable to what the local needs are and what's driving infections locally. Because again, if you try to use something that works in one place, it doesn't actually reflect the epidemiology or the social dynamics going on in another place, it's not going to work and it's going to fail. So you have to be able to, when you design these programs, really suit the local epidemic that's occurring in a given country, a given state, a given county, a given city, whatever it may be, a given village.
That's great. Thank you. Lindsay?
I don't have anything to add.
Yeah.
Thanks.
Okay. Terrific. Well, I think let me see if there are any other questions. Maybe it's a good chance to offer some closing comments from the three of you. Final thoughts from each of you, sort of key takeaways for the audience, or things you want the audience to leave with. Dr. Adalja, we can start with you, and then Lindsay, and then end with Antoinette.
I think that HIV should kind of be a paradigm for how science can solve a problem, but how it won't go all the way without actual implementation of those tools. And I think when you look at COVID or whatever may be coming by, think about the way that the HIV response evolved, how tools were brought to bear, and how this became a much more manageable infection. And I think it only happened because there was a concerted effort to actually treat HIV as this big, health security risk that it was. And if we don't have that for other infectious diseases, you're going to have, the same cycle that we saw with COVID and monkeypox and Zika or whatever it might be. And I think that's the important thing to remember, is that HIV once was an emerging infectious disease. And now we've got this plethora of tools and a lot of public pressure to actually control it. But that didn't just happen. People may have forgotten what it was like in 1981. I was only 6 years old, but I can remember the stigma and issues. That just didn't happen on its own. There was a concerted effort to treat this infectious disease differently than we treated other infectious diseases. And I think it's going to be something that could be replicated for other infectious disease threats if people actually got serious about it.
Great. Lindsay?
I think reflecting on the conversation that we've had, there are four sort of pieces that stand out to me. One is that we keep returning to this question about funding. Are we adequately funding the responses that we need for COVID and HIV and monkeypox in the current moment? And what does funding look like for pandemic preparedness moving forward? Two, the importance of science-based and depoliticized public health, that we really need to regain the public trust in public health, and particularly in communities that already have medical mistrust, and layer on top of that public health distrust that happens in sort of a more population-wide level. Three, the need to have community embedded in responses. And then fourth and finally, the need to lean into policy learning, right? Past experiences shape our policy. We saw that with HIV. We saw advocates shape what happens at the FDA. We saw advocates shape what happens in clinical trials. But policy also shapes our lived experience. So funding in COVID-19 shaped people not facing eviction. And to continue that policy learning cycle and really embed it in future responses is going to be so important moving forward.
That's great. Thank you. Antoinette?
So one thing I thought about just based off a question that we went over was like the urgency and what it looks like after the urgency for HIV has subsided or went down, and we start to see, because of viral suppression and the increase in folks who have obtained viral suppression, and we see a reduction in transmission rates. I think it's important to remember that the people with the experiences and who will continue to live with the experiences have not subsided. So, and nor has the issues that impact them and their communities, such as racism and homophobia and stigma and trauma and so on. So it's important that when we are looking to work with people in this community and we are involving them and including them in decision making and adhering to those Denver principles of meaningfully involving people living with HIV and what that looks like, we are being very unique and purposeful of how we are working with the community. So, and the levels in which we work with them, whether that's on a local level in providing care services, in a federal level, and anything and abroad. And then I think just being sure to be mindful of that. And I'm just trying to think of if there's anything else, but currently I don't have anything. That's all. So thank you.
That's great. I think that's just a terrific note to end on. And I want to thank all of you for spending time with us today, for everything that you're doing, your terrific comments. Clearly, this is such an important health issue, health policy issue in this country. We've made a lot of progress. There's still a lot more work to be done. There are also lessons learned, as you've heard today, from how we've tackled HIV/AIDS that we could apply to monkeypox and COVID. So thank you again for joining us. And to the Alliance, I'm going to turn it back to the Alliance team to conclude today's program. Thank you again to all three panelists.
Thank you so much for a great conversation. Thank you, Dr. Parekh, for leading this conversation. Thank you to Dr. Doucher, Lindsay, and Antoinette for your words and your contributions. Please take the time to complete the brief evaluation survey that you'll receive immediately after the broadcast ends, as well as via email later today. Please join us on Wednesday, October 19th for our briefing, Exploring the Market Competition Ecosystem, Lessons Learned and Next Steps. A recording of this webinar and additional materials will be available on the Alliance website. This concludes our talk today, the state of HIV/AIDS progress and applying lessons learned to current public health emergencies. Again, thank you, Lindsay, Antoinette, and Amesh, and Dr. Parekh for your support. Thank you.